All right, let's set the scene. A patient comes in with a fever, and it's been getting worse day by day, kind of like climbing a set of stairs. You're thinking, this could be typhoid, but how do you actually confirm it? Well, today we're going to break down one of the most classic tools for this exact job, the Widal test. Let's get into it.
So there's your patient with that classic stepladder fever, and your clinical gut is screaming enteric fever. The big question is, how do you go from just a suspicion to a solid diagnosis? Now, while blood culture is the gold standard, we've got other tools in our toolkit.
And that brings us to the star of today's show. We're talking about the Widal test, a serological tool that's, believe it or not, been in the medical playbook for over 100 years.
So here's our game plan. First, we'll cover the basics, what the Widal test actually is. Then we're going to roll up our sleeves and look at how it's done. After that, we'll learn how to read the results, talk about its biggest problems, and then wrap it all up with a high-yield showdown between the two key players, the O and H antigens.
Okay, let's dive right in. First things first, what in the world is the Widal test, and what's the core principle behind it?
At its heart, the Widal test is what we call an agglutination test. Just think of it like this. Your body makes antibodies, little soldiers, to fight off bacteria, the enemies. This test just looks to see if those soldiers are clumping the enemies together in the patient's blood sample. It's looking for these antibody clumps. And a little fun fact for you, it's been around since 1896, all thanks to its inventor, Fernand Widal. Now, let's get down to the nitty-gritty. What are the actual components of the test? And how do you perform it step by step? Okay, so the test uses 4 specific pre-made antigen suspensions. You've got TO for the somatic or O antigen of Salmonella Typhi. Then there's TH for its flagellar or H antigen. We also have AH and BH for the flagellar antigens of Salmonella Paratyphi A and B. Now here's a really important note. We don't use the Paratyphi O antigens. Why? Because they cross-react with the typhoid O antigen, and that would just make the results a confusing mess. The procedure itself is pretty straightforward, really. Step 1, you take the patient's serum and serially dilute it in saline, making a whole range of different concentrations. Step 2, you add each of those 4 antigens we just talked about to its own set of diluted serum tubes. And finally, step 3, you incubate the whole lot in a water bath overnight. This gives any antibodies and antigens time to find each other and react. Okay, the incubation is done. You come back the next day. Now for the most important part. What do these results actually tell you? This is where the real clinical detective work kicks in. So a positive result is visible clumping or agglutination. But here's the kicker. Not all clumps look the same. O-agglutination, that's from the somatic antigen, it looks like small, compact, almost chalky little granules. But H-agglutination, from the flagellar antigen, that forms these large, loose, fluffy clumps that kind of look like bits of cotton wool. Being able to spot this difference is a huge diagnostic clue. It's all about the pattern you see. If you see a rise in both TO and TH titers, you're looking at a Salmonella Typhi infection. If it's TO plus AH, you should suspect Paratyphi A. What if you only see a rise in TO? That suggests a very recent infection, since O antibodies pop up early. A rise in just TH could mean the patient is recovering, or it might be something else called an anamnestic response. And if all the H antigens are up, your first thought should be a past vaccination. Now, as much as we love a classic test, the Widal is far from perfect. It's so important to understand its limitations and how to interpret it in a real-world clinical setting. This is a massive point, especially in parts of the world where typhoid is common. A lot of healthy people are just walking around with low levels of these antibodies from old exposures. This means a single positive test, just seeing that antibodies are there, doesn't really mean much. What you're really looking for is a high titer, or even better, a rising titer. So what do we mean by high? Well, for the O-agglutinins, a titer greater than 100 is generally what we consider clinically significant in an endemic area. That's a key number to remember for your exams. And for the H-agglutinins, the bar is set a little higher. Here, you're looking for a titer greater than 200 to call it significant. So just to recap, that's over 100 for O and over 200 for H. But really, the absolute best, most reliable way to use the Widal test is this. You need to show a 4-fold or greater rise in the antibody titer between 2 separate blood samples taken about a week apart. That's the real proof of an active, ongoing immune response, not just some old baseline antibodies hanging around.
But be careful, because this test can definitely fool you with a false positive. This can happen from what's called an amniotic response. Think of it as your immune system's muscle memory. A completely different infection, like malaria or dengue, can sometimes wake up old typhoid antibodies. A past vaccination, or even just a contaminated lab sample can do the same thing. And, of course, you can get false negatives too. Testing too early in the first week is a super common reason. But there's also this really tricky thing called the prozone phenomenon. This happens when there's actually too much antibody in the sample, which, weirdly enough, stops the clumping reaction from happening. It's a classic exam trap, so watch out for it. All right, to wrap all this up and give you the perfect revision tool, let's put our two main players, the O and H antigens, head-to-head in one final showdown.
And this table just lays it all out beautifully. Let's walk through it. The O antigen is a lipopolysaccharide. H is a protein. H is more immunogenic, meaning it triggers a stronger immune response. Now, this next one is crucial for diagnosis. O appears early and disappears early. That's your signal for a recent infection. H appears later and sticks around much longer. And as we've already covered, their clumps look totally different. Compact and chalky for O versus big and fluffy for H.
So after all that, let's ask the big question. Is the Widal test a perfect diagnostic tool? Well, the honest answer is no, not by a long shot. It has some pretty significant limitations when it comes to sensitivity and specificity. But, and this is a big but, when you use it correctly, when you understand baseline titers, look for that rising titer, and you're aware of all the things that cause false results, it can still be a pretty useful diagnostic aid, especially in places with limited resources. And there you have it, the Widal test in a nutshell. It's a classic, it's imperfect, but it's still a really important tool to understand. If this explainer helped you out, do us a favor and hit that like button, subscribe, and drop a comment to let us know what topic you want us to tackle next.